Welcome to our video on principles of cancer therapy. Let's get started. In this lecture, we'll discuss the principles of surgical therapy, radiation therapy, and medical therapy as it pertains to cancer. And we'll also go over the frequently tested strategies of cancer therapy. So let's begin with surgical therapy. In essence, surgical therapy is characterized by resection of the primary tumor with clear margins. And a commonly tested example of surgical therapy is the so-called Mohs surgery, which will be covered in greater detail in the next two slides. Now, oftentimes, sampling of regional lymph nodes is done at the time of the resection of the actual tumor, and that helps with TNM staging purposes. Lastly, surgical therapy is often used in conjunction with chemotherapy and radiotherapy, and that's to help achieve that synergistic therapeutic effect. So oftentimes it's not done alone. So basically just remember that surgical therapy is often not done alone. As mentioned already, Mohs surgery is a high-yield example of surgical therapy that warrants a deeper discussion. So we're going to dive into this one specifically, even though there are multiple types of surgical resections. This procedure is commonly used to treat skin cancer on sensitive areas, such as the face or the ears, and it involves three basic steps. First, the surgeon removes a thin layer of skin. And second, the pathologist inspects the removed skin under a microscope. And that's actually done in real time. So it's not a day later, the pathologist looks at it. It's while the surgery is ongoing. So those first two steps are repeated until the cancer is removed with clear margins, meaning that no cancer is visible under the microscope on the edges of the extracted skin. Now, once the cancer is completely removed, then the surgeon closes the skin in the third and final step. Now, this approach allows clinicians to preserve as much healthy skin as possible, leading to better cosmetic outcomes for the patients. With that in mind, it makes sense that this is used in sensitive areas like the face. Here's an illustration depicting the basic steps of Mohs surgery, using the nose as an example. So the surgeon removes the visible lesion, the pathologist analyzes that under the microscope, and then the process repeats layer by layer until the entire cancer lesion is removed. So if ever asked about the best next step for treatment of skin cancer on a sensitive area, Mohs surgery will likely be the correct answer. Let's move on to radiation therapy. The basic premise behind radiation therapy is straightforward. Ionizing radiation is concentrated around cancer cells to induce DNA damage and cause subsequent cell death via generation of reactive oxygen species and induce double-strand breaks. And radiation therapy can be used in combination with surgery, as we mentioned earlier, and that can either shrink the tumor in anticipation of surgery. So before the surgery is even performed, you can shrink it with this to make the surgery a little bit more effective or easier. It can also be used to prevent local tumor recurrence after the surgery is over. So you remove the tumor, and then you send this ionizing radiation to that area. Now, there are three primary types of radiation therapy: external beam radiation, brachytherapy, and radioimmunotherapy. Now, external beam radiation is characterized by beams of high-energy X-rays that are generated by a linear accelerator and delivered precisely to the tumor site. Now, examples of clinical application include brain tumors, breast tumors, and lung tumors. So just this big beam of energy that goes right to that area. Now, brachytherapy is characterized by a radioactive node that is implanted at or near the tumor site. Now, the node is designed to deliver a constant and precise amount of radiation to the target site. So basically, you're just placing this little ball of radiation in an area and let it do its magic. And here's when it's used. So you're thinking ocular cancer, prostate cancer, and rectal cancer. At least those are common examples. Lastly, radioimmunotherapy is characterized by a radioactive compound that is conjugated to an antibody designed to target cancer cells and injected into the patient's bloodstream. In other words, think of it as a radioactive payload attached to a homing missile headed straight towards the cancer cells. So you put it in the blood, but really it should just go to those cancer cells because of that attached antibody. Now, the most common clinical application of radioimmunotherapy is in treatment of non-Hodgkin lymphoma. Now, by the way, it isn't super important to memorize the clinical applications of these various forms of radiation therapy. So if you're thinking about what features of this particular table are important, it's only the first column and the second column. So basically, just know that there are three types of radiation therapy and just have a basic idea of how it works. Now let's discuss medical therapy. Generally speaking, there are four primary types of medical therapy for cancer. There's chemotherapy. That's probably the most common one that most people have heard of. Then there's targeted therapy, there's hormone therapy, and there's immunotherapy. Chemotherapy effectively kills all rapidly proliferating cells, which includes cancer cells, but also includes other rapidly proliferating cells, such as hair cells or epithelial cells. Targeted therapy, as the name suggests, targets cells with specific oncogenic mutations. Hormone therapy, on the other hand, treats hormone-dependent cancers, such as breast cancer, because it relies on estrogen, or prostate cancer that relies on androgens. Now, lastly, immunotherapy is designed to prime the host system to target and kill cancer cells. So right now, let's just focus on chemotherapy. Before we dive into those other types of medical therapy, let's spend our next few minutes talking about chemotherapy, especially because these are so highly tested on your board exams, and you're going to need to know these and how these agents work. So let's briefly go over this table, and we'll highlight the most frequently tested topic. Okay, so alkylating agents like cyclophosphamide, cisplatin, or carboplatin work by causing damage to the DNA of cancer cells. And it's important to know that prolonged use of cyclophosphamide may predispose patients to development of hemorrhagic cystitis and bladder carcinoma. And I just want to pause really quick to let you know that all of these drugs have a stellar image mnemonic associated with them in our pharmacology library. So if you have a hard time memorizing these details, which a lot of us do, myself included, then I would highly recommend learning a lot of this stuff and memorizing them using those image mnemonics. But let's continue. So prolonged use of cisplatin or carboplatin, other alkylating agents, can lead to ototoxicity and even peripheral neuropathy. Now let's look at the next group. So antimetabolites are methotrexate and fluorouracil, and both of those work by interfering with DNA synthesis. Now, methotrexate also interferes with folate synthesis, and it predisposes patients to development of megaloblastic anemia, hepatotoxicity, and stomatitis. Now let's go to the next group. Antimicrotubule agents like vinblastine, vincristine, and paclitaxel function by interfering with cell division. Now, prolonged use is particularly associated with peripheral neuropathy and hair loss. Now, anthracyclines is a class of chemotherapeutic agents that includes bleomycin, doxorubicin, and daunorubicin. And these drugs work by interfering with DNA replication and causing apoptosis. Now, it's important to know that prolonged use of bleomycin is associated with pulmonary toxicity and fibrosis. And that's a really high yield side effect. Prolonged use of doxorubicin or daunorubicin is associated with cardiotoxicity, another really high yield adverse effect. Lastly, topoisomerase inhibitors like topotecan or irinotecan also interfere with DNA replication, and both of those predispose patients to significant diarrhea. And again, if this overwhelms you, then I recommend viewing those image mnemonic videos that we have. But keep in mind that those step 1 videos are really focused on step 1, and they're going to have some details that you won't necessarily need as a clinical learner or in preparation for the COMLEX level 2 or the USMLE step 2. And the details that you need to remember from those videos, should you go watch them, are those that are listed in this table. Now let's do a quick question. How can clinicians protect patients from developing hemorrhagic cystitis and bladder cancer that may be caused by prolonged use of cyclophosphamide? To understand the answer to this question, it's important to understand why cyclophosphamide leads to hemorrhagic cystitis and bladder cancer in the first place. So here's how it works in essence. Cyclophosphamide produces a metabolite known as acrolein, which accumulates in the bladder, and while in the bladder, it exerts significant toxicity. And if allowed to persist in the bladder for very long, then acrolein will inevitably lead to hemorrhagic cystitis and eventually bladder cancer. So to prevent this, clinicians should undertake measures to flush acrolein out of the patient's bladder. So this can be accomplished via frequent hydration and voiding, the natural way the body gets rid of things. But you can also use a compound called mesna, and that will bind acrolein and promote its urinary excretion. So in sum, clinicians should always consider these measures whenever prescribing cyclophosphamide to treat cancer. So now we've talked about medical therapy. So now let's talk about targeted therapy. Under the umbrella of targeted therapy, the notable drugs are trastuzumab, cetuximab, and imatinib. Trastuzumab is a HER2 receptor inhibitor used in the treatment of various cancers. And the key to remember about trastuzumab is that it often causes cardiotoxicity, which is why clinicians should strongly consider obtaining baseline echocardiography before prescribing this drug. And that's fairly intuitive. You're very confident that trastuzumab can hurt their heart, so you want to make sure that their heart is good to begin with. Now, cetuximab is an EGFR inhibitor that frequently causes an acneiform rash and may also cause serum sickness. Lastly, imatinib is a BCR-ABL tyrosine kinase inhibitor, and it's commonly used to treat CML, or chronic myeloid leukemia, specifically CML that results from a translocation between chromosomes 9 and 22. So in the context of genetics and chromosomes, the term translocation effectively describes an unusual exchange of genetic information between different chromosomes. And this figure illustrates a translocation between chromosome 9 which you can see on the left, and then chromosome 22, which you can see on the right in blue. And note how a red piece of chromosome 9 has been exchanged for a blue piece of chromosome 22, and that creates the 922 translocation and a BCR-ABL gene. And this specific genetic aberration leads to CML, and it's effectively treated with imatinib. Now let's move on to hormonal therapy. The two most notable examples of hormonal therapy are tamoxifen and anastrozole. Tamoxifen works by inhibiting estrogen receptors in breast tissue, which is why it's used to treat estrogen receptor positive breast cancer. Importantly, tamoxifen increases a woman's risk for developing endometrial carcinoma and uterine sarcoma, and the reason is because it acts as an estrogen agonist in the uterus, so effectively making the uterus respond as though it's getting more estrogen. And with that idea of increased effective estrogen activity, then it also increased the risk of blood clots. Now, anastrozole works by inhibiting conversion of androgens to estrogens by the enzyme aromatase. And similar to tamoxifen, it's also used to treat estrogen receptor positive breast cancer. And the key side effect of anastrozole is increased risk of developing osteoporosis due to the drug's anti-estrogenic effect. And that's kind of what makes anastrozole so easy to remember, is you just need to remember osteoporosis. That's like the main side effect. Now, immunotherapy is among the most novel modalities of cancer. So this is kind of interesting, and I'm excited to talk about it. The two primary classes of drugs are PD-1 inhibitors, such as nivolumab and pembrolizumab, and CTLA-4 inhibitors such as ipilimumab. Now, it's important to know that both PD-1 and CTLA-4 are receptors, and those lead to inhibition of T cells via various mechanisms. So, inhibition of those receptors using these drugs will effectively rev up the immune system and prime it to destroy cancer cells. And it's that revving up that actually causes the side effects as well. For example, mucositis. The body's immune system in that instance is attacking the mucous membranes, and the patient experiences mucositis. In other words, you're revving up the immune system to kill a cancer, but like basically everything with medical cancer therapy, you're getting some side effects and hurting one's own body. Now that we've covered surgical, radiation, and medical therapy, let's briefly go over the key strategies of cancer therapy. In other words, this is where we apply all that stuff we've learned into an actual strategy that you implement for a patient. So generally speaking, there are 6 primary strategies of cancer therapy that are important to know for the boards. So first is adjuvant therapy. This is when additional treatment is given in addition to or following the standard therapy for a particular cancer. So for example, a patient may receive chemotherapy after breast cancer excision. In this case, the breast cancer excision would be the standard therapy, and the chemotherapy that follows it would be classified as adjuvant chemotherapy. In contrast to adjuvant therapy is neoadjuvant therapy, which is when treatment is given before the standard therapy. For example, a patient may receive radiation therapy to shrink a tumor before a scheduled surgical excision. In this case, the radiation therapy would be classified as neoadjuvant radiation as it preceded the surgical excision. Induction therapy is the very first therapy administered to the patient, and it's usually designed to kill tumor cells quickly, potentially achieving remission. For example, a patient may receive high-dose initial chemo for acute leukemia designed to eliminate as much of the cancer as possible. Consolidation therapy is characterized by multi-drug therapy that follows induction therapy. So you induct and then you consolidate. And this form of therapy is designed to kill even more tumor cells, further maximizing the patient's chances of achieving remission. So again, you induct and you consolidate. Now, building on our previous example, prescription of multi-drug chemotherapy to a patient with acute leukemia who has already received initial high-dose chemotherapy would be considered consolidation therapy. And this brings us to maintenance chemotherapy. This is usually given after consolidation, and it's designed to eradicate any remaining tumor cells and or keep the patient in remission. For example, a patient with lung cancer may receive maintenance chemo after achieving remission in order to prevent recurrence of that same lung cancer. So induct, kill as much as you can, then consolidate, kill more, and then maintain, basically trying to prevent recurrence. So lastly is salvage therapy. This is usually offered following either cancer recurrence or when the initial therapy fails. So the purpose for this is to, once again, help the patient achieve remission. Now, a common example of salvage therapy is multi-drug therapy used in treatment of patients with diffuse large B-cell lymphoma, which is a particularly aggressive cancer, and it's difficult to send into a remission with just the initial therapy alone. And my use of the term initial therapy here is assuming you've done induction, consolidation, and maintenance. And then the B-cell lymphoma comes back. It's that diffuse large B-cell lymphoma. And so salvage therapy is ideal. So in sum, the key to this table is to understand the differences between these 6 general approaches to delivering cancer therapy and be able to distinguish the difference between all of these because examiners really like to test them on boards. And it's helpful clinically. Now let's wrap up with a board style question. A 33-year-old 33-year-old male presents to clinic with a chief complaint of worsening shortness of breath. He has a known history of testicular cancer for which he underwent a prolonged course of multi-drug chemotherapy. The patient says he's been in remission for about a year. Blood pressure is 135/87, temperature is 37.2 degrees Celsius, pulse is 74, and respiratory rate is 19. Physical examination is notable for fine inspiratory crackles at lung bases. A chest x-ray is obtained and reveals reticulonodular opacities. A follow-up CT scan of the chest reveals interlobular septal thickening and honeycombing. The pulmonary findings can most likely be attributed to which of the following chemotherapeutic agents? A. Cyclophosphamide, B. Carboplatin, C. Vincristine, D. Bleomycin, or E. Irinotecan. So the correct answer here is D. Bleomycin. So this is a case of a 33-year-old male, known history of testicular cancer, and now presents with shortness of breath, and it's worsening. So it's also important to know that his cancer is now in remission after a prolonged course of multi-drug chemotherapy. So the findings of fine inspiratory crackles on physical exam and what you see on the chest x-ray, the reticulonodular opacities, as well as the interlobular septal thickening and honeycombing on CT, are all consistent with pulmonary fibrosis. So among the listed chemotherapeutic agents, only bleomycin can lead to pulmonary fibrosis after prolonged use, which is why that's the correct answer. Now, option A, cyclophosphamide, is associated with hemorrhagic cystitis and bladder cancer. Remember, cyclophosphamide creates that acrolein that just sits in the bladder and causes these issues. But it's not known to cause pulmonary fibrosis. So A is wrong. Now, option B, carboplatin, is associated with ototoxicity and peripheral neuropathy. Now, option C, vincristine, is associated with hair loss and peripheral neuropathy. And lastly, option E, irinotecan, is most commonly associated with diarrhea. And that concludes our lecture on the principles of cancer therapy.